but they are a known heart failure patient, and they are now septic with
Are now
Rigers.
septic. Okay.
Yeah. So I'll show you the CT file.
Okay. Right. Okay. So bilateral. Sorry, I'll just have a better look at that. Okay. Can I just see the left main pulmonary artery as well? I just want to see if there's.
It doesn't go high enough. It's a cardiac CT.
That's all right. Okay. So there are, so left pulmonary artery demonstrates a central filling defect in keeping with an acute pulmonary thromboembolism. There are wedge-shaped bilateral posterior basal consolidative and ground glass changes with areas that have sort of interlobular septal thickening. These are in keeping with pulmonary infarcts in the presence of pulmonary embolism. I also noticed that in the left kidney, there was a wedge-shaped area of hypoattenuation that is extending to the renal cortex. I cannot appreciate a cortical rim sign. I would interrogate the left renal artery in detail to exclude a filling defect. However, this appearance to me is suspicious for a left renal infarct. So in summary, there are multiple, so there are pulmonary and renal infarcts. And in a patient with heart failure, I would be worried about thromboembolic causes, such as atrial fibrillation or an irregular heart rhythm. It is I would interrogate the heart to just exclude, atrial septal defects or any other abnormality, but I can't appreciate that. And I think there is also a filling defect in the left ventricle. Which I suspect is most likely a thrombus, just because this will be the most common etiology. Having said that, I would like to interrogate it and assess its attachment to the, if there's any attachment to the adjacent muscles, which I cannot appreciate any attachments. So this is likely a thrombus in the left ventricle as well.
Mm-hmm. So what are the infarcts then?
So could the infarcts be this thrombus is throwing off microemboli and causing infarcts?
So what are you concerned about in the patient's history?
So I would be concerned about a possible etiology. So what is causing the thrombosis? So what causes of thrombogenesis or having an increased risk of thrombus? So atrial fibrillation would be one. Is there a myocardial infarction or an aneurysm secondary to previous infarct? And actually looking at the cardiac wall, is there some thinning of the, I could be overcalling here.
No, it's dilatation because he's in heart failure. It's just a dilated LV. But in terms of history, are you concerned about any underlying drug history, or would you think that?
Yeah, I'm thinking about, so first I would review the patient's biochemical markers if they're available to me, and just check that he's not in a hypercoagulable state. Other things I would think about would be medication that would cause thrombogenesis. Is that what you're hinting at? I'm not actually. I haven't picked it up.
No, that's you digging a hole.
Okay.
Can you think of a medicine that gives you thrombus in the heart? I'm talking about drug abuse. Okay, last one. Have a go. We have 4 minutes. I think we can squeeze this in.
Okay. This is the last one? Okay.
Yeah.
I thought it was the one I saw previously.
No, this is in, so I want to see if you got
right. Okay. So I am presented with a frontal radiograph of the chest. There is a right peripheral opacity abutting the right chest wall with an obtuse margin to the chest wall and some pleural thickening in that region. I I suspect that this is a pleural-based mass. I can't see any underlying destructive bone changes, but because I can see underlying pleural thickening, I am looking to see for signs of previous asbestos.
Okay, the first question is, I have a question about the military TB case. On the CT, there was a mention about tree and bud, but the diagnosis was military. I think the word is miliary, and you're writing military, so that's one thing to correct. We have to call it miliary TB. Miliary TB is, like you said, hematological spread. The patient does, when somebody is immunocompromised, they have a bit of everything going on, and this patient was actually reacting to a drug as well. So this was a mixed diagnosis of hypersensitivity with superadded atypical infection. But in miliary TB, you should not have tree and bud. In endobronchial spread of TB, you have tree and bud and all these nodules. When you have central lobular nodules, that implies that there's something inside the airways. So yeah, that's if that was TB, it wasn't miliary, it was endobronchial spread of TB. Is the lower right vasculature on this chest X-ray normal? Yes, it is normal. This one on the screen right now, this is normal. With age, you get this sort of blunting of the diaphragms bilaterally quite commonly, but like you have to say, it could represent small pleural effusion, but this is just common pleural thickening in elderly patients. This right lower lobe vessel can look quite prominent in many people, but this is normal. If you are concerned that it looks prominent, you try to follow it. If it's something linear, the likelihood of that being a vessel is more. And then you follow it back to the hilum and think what lesion can look like that. I can't think of a lesion that looks linear like that is coming out of the hilum towards the base, which can only be a vessel. Isn't myeloma plasmacytoma a purely lytic lesion? Why does it appear soft tissue density in the final case? A lytic lesion is something that destroys the bone. When bone is destroyed, it doesn't result in air or fat. It looks like soft tissue. So it doesn't calcify, it's just the bone expands and it can look like soft tissue. Miliary can be ground glass. Yes, it can be. How to differentiate between collapse and consolidation? That's a good question. Usually they both happen at the same time. So that's one way to get out of a tricky spot. If you can't make up your mind, something has to have consolidated before it collapsed. So it's quite common to see in reports there is collapse consolidation. Collapse doesn't always mean there is something wrong with that part of the lung. Collapse can be secondary to something proximal to the lung. Collapse just means that part of the lung deflated. So collapse has to cause volume loss. That part of the lung has to get smaller. Consolidation alone is replacement of the air spaces with something else. It could be blood, it could be pus, it could be blood, water, or inhaling something, or a reaction, exudative collection inside the air spaces. So consolidation means normal lung volume air is replaced by something else. Over time, that part of the lung gets so underventilated that it starts collapsing. The body starts pushing air into it and just gives it a lower volume and it collapses. So the way to differentiate on X-ray is you want the fissures to move. The fissures have to go towards that area of abnormality, and that means collapse. Sometimes in consolidation, you can have increased volume as well, and that's a very typical sign of a certain infection. I don't know if you guys remember it or not, but when you say consolidation that is causing increased volume or bulging of the fissures, that's a typical sign for Klebsiella pneumonia. So that may be something you get asked, is a consolidation that has a mass effect or is pushing the fissure. You have to think of cancer, and if it's an infection, it would be Klebsiella. So I hope that answers your question. Would you consider brown tumors if old and plus fibrous? Yeah, you would, but that's a discussion for the Viva. Common things commonly is myeloma more common. Fibrous dysplasia, you tend to get asked for more for pelvic bones, or it's a more obviously anything can look like anything. On this last case, why could this not? I can't keep track of the chat. It's moving too quickly. For the sarcoidosis case, silicosis in cold worker can also cause lymph node calcification. Was it the posterior predominance that made sarcoidosis more likely? Yes, absolutely. It was the typical appearance. In cold workers, pneumoconiosis, you tend to get lung calcification as well. That's something silicosis, sarcoidosis does not tend to do. The nodules you get in pulmonary sarcoidosis, they don't tend to calcify. Whereas in cold workers, you tend to get lung nodule calcification as well. And the lung is a bit more um, rough looking, dirty looking, scarred looking. What management can we suggest for end stage sarcoidosis? Nothing. It's irreversible. And those patients are usually under follow up. Sometimes they tend to get a flare. So somebody with stage 4 sarcoidosis can have a flare and they can develop parenchymal or the nodules again. And that's when they need treatment. But purely fibrotic sarcoidosis does not have a treatment. Posterior lung fibrosis, why not post-respiratory distress syndrome? Because it wouldn't be upper lobes. Post-ARDS, lung tends to be posterior. Yes, you're correct, but they don't tend to favor the apices. It doesn't go that high. Ma'am, can we have one time? Of course you can. It's up to Dr. Sami to invite me back. I'm happy to come back. Post-lung fibrosis, why not TB? It can be TB. In TB, when you get fibrosis like that, the lung has cavitation. The lung has a lot more asymmetrical scarring. You get bronchiectasis, you get scarring and cavitation. So I can show you a case next time for TB to put it side by side to you so you can appreciate it. But yes, purely on X-ray, yes, you can talk about TB. But when it comes to that CT, you should think of sarcoidosis only. On this last case, why could this not be a pleural met with rib destruction? It absolutely can be, absolutely. And if I was the candidate, I would have said pleural met with rib destruction or a bone met, vice versa. It definitely can be. You cannot differentiate purely on X-ray. But the take-home message should be that if you see that on a chest X-ray, you have to pick the bone destruction and you have to call it cancer. You have to escalate appropriately, considering the patient likely has cancer, either primary or metastatic. So it doesn't matter whether you call it pleural or bone. You can't differentiate on X-ray. Can't see any more questions. Sigmoid or sequel. Go back. I've anonymized the cases now. I can't find them. Can't find the case for some reason. What are the differential for expansile meds? I think the last candidate answered that quite well. She said renal, thyroid, breast can cause pretty much anything. Breast is the only primary that can give you sclerotic and lytic bone metastasis. So if in doubt, breast can pretty much cause any kind of bone mets. But the differential the last candidate gave was pretty accurate for expansile bone mets. Please tell me how to differentiate interstitial lung disease from lung pneumonia. That's probably a lecture rather than a 2-sentence answer in terms of differentiating interstitial lung disease from pneumonia. But the simple answer is consolidation. You want to see haziness and on a bigger scale and consolidation to call something pneumonia. Interstitial lung disease needs to give you a reticulation that gives you lower lung volumes. You need to see reduced lung volumes to go down the ILD route. If you have haziness, general haziness, you need to talk about pneumonia, or if in doubt, pneumonitis is a good word, because pneumonitis doesn't really commit to infection or idiopathic process, because in the beginning, ILD, like drug-induced or something, can look like pneumonia. So pneumonitis is a good word to get out of that situation. But differentiating ILD from pneumonia is a long conversation that we can probably pick up another time. That's okay. Okay, thank you.
Samavia, that is, I think, all. There is a, what is this? The nitrofurantoin induced. Okay, that is just a comment. So thank you very much. You can hear me, Samavia. You can.
Yes,
hear
I
me?
can.
So
Yes.
fantastic session. Thank you very much. And you have already promised them a session. So we will, of course, the invitation is on, and on popular demand. I hope to see you soon. We will discuss whenever is your availability, another session whenever it suits you. So thank you very much. I believe they really, the teaching points, the learning points were actually learning points for myself also. And chest, I believe, is the most commonly asked single examination in the exam. And chest X-ray, of course, is the most popular. So I think they will need more sessions from yourself, and this will be extremely useful. So thank you very much once again.
Thank you for having me. Thank you, everyone.